Good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaj. NEETPG patterns. Every time when we prepare for the NEETPG entrance, we will be thinking, we have to see all those videos in the tab. Oh my God, that notes is good, this notes is good. But what is the secret of winning? It is not the notes, how much you read. It is not about Harrison, what you read. It is not about how many videos or face-to-face classes you attended. What is the most important factor to crack the top rank in NEETPG? You need to know the pattern. What examiner wants. If you are well prepared, all the 200 questions look like wedding invitation cards. You know what to expect, what to do, what to answer in the exam. It should be such a holiday to which you need to go when you go for the NEETPG entrance. So today, ChatGPT brought a lot of AI into what a NEETPG examiner thinks. You give one MCQ and you say what is the pattern you need to remember. It will throw you all the required things you need to remember. Earlier, we used to go to books like first aid, etc., to do that. But today, it is not the story. Today, it is the guy who knows these 5,000 patterns of the examiner based upon 2,000 PYQs of the NEETPG in the last 12 years and 4,000 PYQs of INI-CET. Once you go through each MCQ, PYQ, and know what is the pattern, what are the 8 to 10 boxes of info that you need to master, sure shot to come in the exam, then you know how to crack all the 200 questions at ease. Let's make the great beginning. Every day, we will discuss around 60 PYQs. In about 100 days, we will be able to finish all the 6,000 PYQs falling into 5,000 patterns, which are frequently repeated in the exam. So let's make the great beginning, doctors. Am I audible? Can check, yeah. So can you please ask her to, yeah. So doctor, a patient presents with no pulse and the ECG is showing this rhythm, which is a broad complex QRS, which is ventricular tachycardia. So what do you want to do in ventricular tachycardia was the NEETPG 2024 question. So the answer, all of you know, we need to defibrillate, perform the CPR, and check the pulse. So what is there in examiner's question bank? What kind of a patterned question is going to come in the future exams? Basically, shockable, non-shockable. Ventricular fibrillation and pulseless VT are shockable. The first step is defibrillation. If it is non-shockable, asystole and pulseless electrical activity, there you need to do CPR and give epinephrine. So no pulse, but VT or VF, shock first is considered to be the management. And you need to know what is the ACLS algorithm. So based upon the 2024 MCQ, 2024 NEETPG exam MCQ, PYQ, you need to be ready with all these tables. First, defibrillate, CPR in 2 minutes, check the rhythm. If it is persisting, shock again, give epinephrine, repeat the cycle, and add amiodarone is considered to be the ACLS protocol. Now, the drug table, favorite question of the examiner. After second shock, give epinephrine 1 milligram IV. After third shock, give amiodarone 300 milligram IV. So don't check the pulse immediately after the shock. CPR first and then check the pulse is considered to be the ACLS protocol. So whenever it is a non-shockable rhythm, pulseless electrical activity, asystole, then you need to start CPR immediately, give epinephrine 1 milligram IV, repeat every 3 to 5 minutes and search for the causes that is leading to this asystole and pulseless electrical activity. You need to know what are the H's and T's when it comes to pulseless electrical activity. There is no role for defibrillation in asystole or pulseless electrical activity. Favorite MCQ of the NEETPG examiner. So whenever there is a VT, broad QRS complex tachycardia, if the patient is hemodynamically stable, you treat with imidazole. If he is hemodynamically unstable, then you need to give synchronized cardioversion. Is a very important role. And there is no role when the pulse is present, there is no role for the defibrillation is what you have to basically remember. Then VF versus VT, quick differences you need to know for the next NEETPG exam. The rhythm is chaotic in case of VF, whereas it is regular in VT. QRS is irregular in VF, but wide QRS in VT. And the pulse is absent in VF, but present in case of VT, may be present. There can be pulseless VT also, hemodynamically unstable. Now, what are the shock types? Whenever it is a VF or a pulseless VT, defibrillation, which is unsynchronized. Whenever there is any VT with pulse, then you need to do cardioversion synchronized. There is no role for defibrillation when there is a pulse. You can't, when the pulse is there, you can't give unsynchronized shock, is what you have to remember. Now, quickly tell me, doctor, the NEETPG examiner's pattern remembers about H's and T's. H, hypoxia, hypovolemia, hydrogen ion, that is acidosis, hyperkalemia, hypokalemia. They can lead to development of pulseless electrical activity and asystole. What are T's? Tension pneumothorax, tamponade, toxins, and thrombosis. Thrombus in the coronary, myocardial infarction, thrombus in the pulmonary artery, which is pulmonary embolism. The 4 H's, 4 T's about the pulseless electrical activity and asystole, you need to be very sure about. So you need to have ready in your pocket, because you need to know the pattern of the examiner. What are the arrhythmias? What is the drug of choice? Whenever there is a ventricular fibrillation with a pulseless VT, what will you do? Defibrillation, shock first. Stable VT, imidazole. And you look for wide QRS to confirm it is a VT. Unstable VT, you need to do cardioversion if the pulse is present, not defibrillation. Cardioversion is a synchronized shock. Then Tosides depointus, which is a polymorphic ventricular tachycardia. You need to give the magnesium sulfate. Commonly, it is a long QT interval, more than 600 milliseconds, that lead to Tosides depointus. When there is a PSVT, supraventricular tachycardia, you need to give adenosine, which is the treatment of choice. It will have a sudden onset and sudden offset. Similarly, atrial fibrillation, for the rate control, you will give beta blocker or diltiazem when it is irregular. Whereas for the rhythm control in atrial fibrillation, you need to give imidazole, is the drug of choice for the rhythm control. Atrial flutter, you need to give beta blocker. It will have a sawtooth shaped ECG. And whenever there is any sinus tachycardia, there will be some underlying disease like hyperthyroidism can cause sinus tachycardia. Pulmonary embolism, you see sinus tachycardia. Fever, anxiety can lead to sinus tachycardia. you need to treat the underlying cause in case of sinus tachycardia. Then quickly you must be ready with the NEETPG pattern of the examiner, bradyarrhythmias. So when there is a symptomatic bradycardia, patient is having giddiness, then you need to give atropine, parasympatholytic drug of choice. If it is a refractory bradycardia, you need to give dopamine or adrenaline. And if it is a complete heart block, like in the case of right coronary artery occlusion, inferior wall MI, whenever you get a complete heart block, which is not reverting to the atropine, then you need to do temporary pacing, which is the definitive treatment, is what you need to remember. Once more, some of the important NEETPG patterns you need to remember. Whenever there is a aberrant pathway between atria and ventricles directly, WPW with AF, there you should not give beta blocker or digoxin, because that will make AV node refractory and make the transmission through this abnormal pathway more, which will worsen. That's the reason when WPW plus AF is there, how do you treat, doctor? Procainamide is considered to be the treatment of choice. Whenever there is any digoxin toxicity leading to arrhythmia, then you need to give lidocaine or phenytoin. Long QT syndrome, we give magnesium. Whenever SVT with asthma is there, you can't give beta blockers. We need to give verapamil, the calcium channel blocker. And after MI, when there is an arrhythmia, amidaron is considered to be the safest drug of choice to treat the arrhythmias after the MI, is what you have to remember. Then what to avoid is the favorite MCQ of the examiner. When WPW plus AF is there, don't give any drug that will make the AV node become refractory. If you give digoxin or beta blocker, that will make AV node refractory and the conduction through the aberrant pathway to become more and more and more, which is deleterious. Many times this was asked as a PYQ in the entrance exam. It is sitting in the examiner's question bank. You need to be ready. When torsitis is there, never give amidaron. When there is a severe bradycardia, don't give beta blockers. These are the important rules to avoid. Now, finally, ultra rapid revision, you need to have few things in your pocket. No pulse, chaotic rhythm, defibrillation. Long QT, polymorphic VT, magnesium. Sudden palpitations with a narrow QRS, it is SVT. You need to give adenosine. Irregular pulse, you need to give, it is AF, beta blocker. Wide QRS tachycardia, VT, amidaron. If there is a slow pulse with hypotension, you need to give atropine. So this is all the NEETPG patterned tables that you need to remember. Can the online students can punch? Is the voice loud and clear, doctor, for all of you? Thanks for joining this session. There are totally 5,000 NEETPG patterns you need to master. The tables which are sitting in the examiner's database tables, from which straight questions will come into your 200 MCQ paper in the NEETPG. You must be ready. How will you do that? Go and do the reverse engineering of the PYQs. Looking at every PYQ, try to guess what all the things that I need to remember. Because this question is the PYQ. What is the big iceberg which is sitting behind it? All right. So that is what you need to basically do, doctor. Now, the next question in NEETPG 2024. Which of the following is true regarding this EMLA? So you need to be very sure. EMLA can lead to Methemoglobinemia. What is EMLA? Eutectic mixture of the local anesthetics is EMLA. What does it have? Lignocaine, prilocaine. What is the ratio? 2.5, 2.5, total is 5%. It's a topical anesthetic cream. It leads to the blockade of the sodium channels. Common trap of examiner. Does it contain ropivacaine? No. Does it contain 5% lignocaine? No. These are the exceptions you need to basically remember. Now, the prilocaine can lead to methemoglobinemia, which oxidizes the Fe+2 to become Fe+3. Lignocaine leads to CNS toxicity, though it is rare topically when it is used. And it typically causes it by blocking the sodium channel. So the most common side effect asked in the exam is EMLA, because of the prilocaine can lead to methemoglobinemia, is what you need to remember if you need to survive NEETPG. Now, what are the patterned tables sitting in the examiner's database in the question bank, which are going to come, and we must be ready as a last moment revision before the exam. The prilocaines metabolite is O-toluidine that lead to methemoglobinemia. Fe+2 become oxidized to Fe+3. Oxygen delivery decreases, the blood becomes chocolate brown. We use methylene blue to treat methemoglobinemia. And if you do the oxygen saturation, typically the exam trap, the pulse oximeter 85%, despite the presence of oxygen saturation is low, which is a very important clue. Now, in spite of your giving oxygen to the patient, hemoglobin doesn't know how to use that oxygen because Fe+3, it is not Fe+2. So typically within 45 to 60 minutes it happens. Peak effect is in 1 to 2 hours. And whenever you use EMLA, EMLA's action will start within 1 hour, peak in 1 to 2 hours. Typically, when we are doing venipuncture, minor procedures, we use the EMLA. It is not 15 minutes, it is 45 to 60 minutes before the onset of action of this eutectic mixture. So, since the examiner in the NEETPG 2024 asked you about prilocaine in EMLA and the methemoglobinemia, ask the ChatGPT, give me the pattern. It will bring out every examiner's question bank hacked and will give you what to remember for the exam. Bupivacaine, severe arrhythmias, most cardiotoxic. Ropivacaine, less cardiotoxic and safer alternative. Lignocaine can lead to arrhythmias, even at low dose, because it is a class 1B agent. So bupivacaine lead to fatal arrhythmias, bupivacaine and cardiotoxicity, favorite question of the examiner. Now, methemoglobinemia, most commonly prilocaine. Even benzocaine can cause, is what you need to basically remember. Now, let's look at all the anesthesia and the various adverse effects. The pattern of the examiner to ask in the next exam. Ester local anesthetics, they release PABA, and typically they lead to allergic reactions. Procaine is an example. Amide local anesthetics like lignocaine, when there are two I's in the spelling of lignocaine, what do you have? L-I and once more cane, one more I. Two I's amide, one I ester in the spelling. So ester lead to allergy than amide. How will you remember? Allergy has alphabet E. Ester is having E. Allergy is more with the ester. Ester has only one I. One I, not two I's. is what you have to remember. Now, once more, how will you remember in the exam hall? One I is ester, two I's are amide. A means first letter, but it has two I's, lignocaine. Other one is ester, which has only one I in the spelling. So first you need to know what are esters, what are amides. Then esters cause allergy more than the amides. That is what you need to remember. Allergy is A, but A is not A. Amide is not allergy. Ester is allergy. That's what you need to remember. So, doctor, in the NEETPG, what is important is what to remember, how to remember, how to recall. These three things we should know. Now, specific toxicities is a favorite question. Cocaine lead to vasoconstriction. That's the reason generally we add adrenaline to increase the local action of the local anesthetic. But cocaine doesn't need because it already has got vasoconstrictive ability. Cocaine is sympathomimetic, hence it leads to hypertension. Prilocaine lead to methemoglobinemia and cyanosis. Bupivacaine is cardiotoxic, cardiac arrest, and it is refractory cardiac arrest. Antidotes is ultra important, doctor. Seizures, whenever they are there because of the anesthesia, benzodiazepines are used to treat. Similarly, to avoid the cardiotoxicity, try to give lipid emulsion. Methemoglobinemia countered by methylene blue is what we should remember. So quickly summarize, doctor, all about the toxicology in anesthesia. Favorite question. Bupivacaine, cardiotoxicity, heart arrhythmias. Prilocaine, benzocaine, they both are methemoglobinemia. Cocaine, vasoconstriction. Cocaine lead to hypertension, tachycardia. Lignocaine lead to CNS toxicity is what you have to remember. Now, what are the IV anesthetics and their toxicity profile in one buzzword that you need to remember? Propofol can cause hypotension. Propofol can cause pain on injection. Thiopentone is a barbiturate, ultra short acting. It leads to respiratory depression. Ketamine leads to emergence delirium. Ketamine increases the BP and heart rate. Everything increases with ketamine. Etomidate can lead to adrenal suppression and decrease the cortisol. So these are the classical MCQs in the NEETPG exam. You must be ready when you go to the exam hall. Because the examiner asked EMLA. Tomorrow he will ask this also. And in fact, the only anesthetic that rises the BP, everything else will decrease the BP, is ketamine, is what you need to remember. Now let us go to inhalational anesthetics and the side effects. Halothane, hepatitis, halothane, arrhythmias, because halothane will go sensitize the heart and lead to the development of arrhythmias. What is the effect of nitrous oxide, doctor? Nitrous oxide can lead to diffusion hypoxia, leading to postoperative hypoxia. Nitrous oxide expand the air spaces. It leads to expansion of pneumoperitoneum. It can lead to air spaces to get blown up, is what you should remember. Isoflurane lead to vasodilatation, hypotension. Sevoflurane rarely can cause nephrotoxicity because of the compound A, but sevoflurane is safe in pediatrics. Sishu is sevoflurane, is what you should remember. Is it? Please check. And also this. Yeah. Malignant hyperthermia is a favorite side effect which you need to remember. Succinylcholine, halothane. These are two things you should remember when it comes to malignant hyperthermia. There's a hyperthermia with increased temperature, muscle rigidity with the spasm of the masseter, It is the ryanodine receptor mutation, and we treat by giving dantrolene is what you should remember. Now, depolarizing, non-depolarizing muscle relaxants. Because examiner asked you about the EMLA, methemoglobinemia, you should be ready with all the adverse effects as a part of the pattern, NEETPG pattern. Succinylcholine, hyperkalemia. Succinylcholine, malignant hyperthermia. Succinylcholine, because of the vagus stimulation, lead to bradycardia. Succinylcholine, because of the pseudocholinesterase deficiency, leads to the development of prolonged apnea, is what you need to remember. Now, what are the non-depolarizing agents and what are the adverse effects is the favorite question of the examiner. Etracurium typically lead to release of the histamine, and that lead to vasodilatation, hypotension. Etracurium releases a product called laudanum that lead to seizures. Pancuronium is vagolytic and lead to tachycardia. Vecuronium, very minimal CVS effects and very stable. Vecuronium. Rocuronium, very rapid in onset, is what you have to basically remember. Then reversal of the drugs is also favorite question of the examiner. Neostigmine typically lead to bradycardia, and muscarinic stimulation lead to that. Hence we combine neostigmine plus atropine will prevent the bradycardia. Sugammadex is the drug which is used to reverse the rocuronium. It is a selective binder to rocuronium. So these reversal drugs is a favorite MCQ of the NEETPG examiner. So the final NEETPG rapid recall, before you go to exam, you must have in your pocket pattern of the examiner doctor. Because the pattern can only save you, not voluminous videos, voluminous notes will be able to help you. Be very sure about it, doctor. EMLA 5%, 2.5, 2.5 is the lignocaine and prilocaine. Bupivacaine spinal, we use 0.5%, lignocaine spinal 5%, halothane MAC value 0.75%, N2O MAC value is 104%, adrenaline is used in 1:200,000 dilution. So 5.5, 5.75 and 104. EMLA, bupivacaine, lignocaine, halothane, nitrous oxide. Be very sure. These are the numbers when it comes to the anesthesia. You need to basically remember that. Now the question number 3, once more, NEETPG 2024. Every question should make you to identify what examiner want, what examiner is testing must be there. आपके मुट्ठी में रहना चाहिए. So now, doctor, identify this medial pectoral nerve, which is marked here. So now, what are the nerves of axilla? What is the pattern of the examiner? Nerves of axilla, what is the muscle supply? What is the clinical injury? Tips में रहना चाहिए. Medial pectoral nerve, CAT1, pectoralis minor and major. Pierces the pectoralis minor, very important. Lateral pectoral nerve, C5, C7, pectoralis major, it does not pierce. So piercing pectoralis minor is always medial pectoral nerve, is what you need to remember. So quickly, doctor, axillary area, what are the nerves? Master table, ratta marna padega, long thoracic nerve, serratus anterior, winging of the scapula, very common, C5 to C7. Thoracodorsal is C6 to C8, latissimus dorsi, weak adduction, climbing difficulty, thoracodorsal. Middle pectoral nerve, C8 to T1, pectoralis minor and major, and there will be a weak pushing. Lateral pectoral nerve C5, C7 pectoralis major, mild weakness of the antherothoracic muscles. Then axillary nerve C5, C6 supplies the deltoid. There is a loss of abduction typically whenever surgical neck of the humerus fracture is there. It is the axillary nerve which you need to remember. So the winging of the scapula is long thoracic nerve. Cannot climb or pull is thoracodorsal. Difficulty in pushing like bench presses, pectoral nerves. Cannot abduct the arm 15 to 90 degrees is axillary nerve. One of these ditto will come in tomorrow's exam. So medial pectoral is C8, T1. Lateral pectoral is C5, C7. Medial pectoral pierces supplies the pectoralis minor is what you need to fundamentally remember. So finally, the nerve piercing muscle is medial pectoral is what you need to remember. Posterior axilla, you have thoracodorsal. Along the chest wall, you have long thoracic. So these are the important points. Now, the question number 4 from the NEETPG 2024 that make you to realize what the examiner is going to ask you in the tomorrow's NEETPG exam. Now, behind the medial malleolus and in front of Achilles, which artery is present? It is the posterior tibial artery. So everything, anything about the ankle, the blood vessels, the ligaments, the tendons, every time NEETPG's favorite question, it is sitting in the examiner's question bank. So now, doctor, what are the tarsal tunnel contents most repeated in NEETPG exam? You need to remember Tom, Dick, and very nervous Harry. T, tibialis posterior. D, flexor digitorum longus. A, posterior tibial artery. V, posterior tibial vein. N, tibial nerve. H is flexor hallucis longus is what you need to remember. In this, posterior tibial artery lies behind the medial malleolus is what you have to remember. Now, posterior tibial artery is behind medial malleolus. Dorsalis pedis is between first and second metatarsal. Antitibial artery ultimately become dorsalis pedis and it is supplying anterior compartment. Peroneal artery is not palpable, it is deep posteriorly located is what we have to remember. So where do you feel femoral pulse, doctor? Midinguinal point. Popliteal fossa. Posterior tibial, behind medial malleolus. Dorsalis pedis, dorsum of the foot between first and second metatarsals is what we need to remember. So whenever there is any peripheral arterial disease, there is an absent dorsalis pedis and posterior tibial pulse. Tarsal tunnel syndrome, tibial nerve is the one which is compressed. And in the diabetes, to know the vascular sufficiency, we do the posterior tibial pulse assessment and calculate ankle brachial index to know the peripheral vascular disease is what we need to remember. So behind the medial malleolus, when the examiner asks you the question, it is the posterior tibial artery which you need to remember. The covering of an omphalocele, what is there? Amnion is there. So doctor, congenital abdominal defects, coverings, contents, associations is the NEETPG pattern which is being tested, doctor, which you need to be doubly sure about. Omphalocele versus gastroscus. Very high yield table, which you need to be very sure about. So basically, omphalocele is covered by amnion plus peritoneum. Gastroscus has no covering. Midline umbilicus is omphalocele. Right of umbilicus is gastroscus. Even though stomach is on the left, gastroscus is on the right to the umbilicus is what we need to remember. So omphalocele has liver plus intestine. Gastroscus only intestine. Umbilical cord is present, in the sac in omphalocele, and it is present separate in gastroscale. Trisomy 13, 18 like syndromes are associated with omphalocele, and the prognosis is poor with omphalocele, whereas gastroscale is better prognosis. Invariably, examiner will ask you one question on omphalocele or gastroscale. You need to be doubly sure about. Sac present omphalocele, no sac gastroscale. This is a very important rule you need to remember. So amnion is derived from the ectoderm plus extra embryonic mesoderm. Chorion from trophoblast plus mesoderm. Peritoneum is from mesoderm and the lining of the gut is from endoderm. Embryology origin is sitting in the examiner's question bank. You need to be doubly sure about it. So rapidly, you need to remember covered with sac, omphalocele. Exposure to loops, gastroscale. Midline defect, omphalocele. Right side defect, gastroscale. You have to do the revision sitting with your classmates. Then omphalocele, trisomy 13, trisomy 18, Beckwith-Whitman syndrome is omphalocele. Whereas a young mother, whenever she is there, gastroscale is a greater probability. So these are the important things. Naked bubble is gastroscale, covered with amnion is omphalocele. The final NEETPG pattern, you have to be 100% sure about, doctor. Now, a 13-year-old boy presents with jaundice, fatigue, muscle stiffness, tremors, behavioral changes, hepatosplenomegaly, KF rings. What is the definitive test? So it is the serum celluloplasmin. All options look same, but serum celluloplasmin. Now, what are the important NEETPG patterns that you need to remember? So, Wilson disease, what is screening, what is definitive, what is confirmatory, all this you need to be sure, doctor. Screening, serum ceruloplasmin, which is decreased, it is first line. Then what supports your diagnosis? Urinary copper 24 hours increased, it is helpful. But what is gold standard? Liver biopsy you do to look for the copper, enormously increased, that is definitive. And what is confirmatory? We do ATP7B genetic testing, which is the mutant, that is confirmatory. So NEETPG often expects you to tell ceruloplasmin is screening, liver biopsy is gold standard. Please don't make a mistake. So quickly tell what is the complete biochem. Ceruloplasmin decrease, serum copper decrease, free copper increase, urinary copper increase, hepatic copper on biopsies severely increased. Don't forget the combination. So you get KF rings, tremors, dystonia, cirrhosis, hepatitis, behavioral changes, psychiatrist, hepatologist, neurologist, ophthalmologist, anybody can catch the Wilson. Now what is the difference between Wilson and hemochromatosis? Hemochromatosis is more older at time of diagnosis. Wilson is younger. KF ring is Wilson. That's the fundamental difference. Now, what is the drug of choice? How do you treat Wilson? Penicillamine is used to do the chelation. But if there is any liver dysfunction, you can't use penicillamine. That is the point where you have to give trientine hydrochloride. Trientine is the alternative. And we use the zinc in Wilson's to decrease the absorption. That's what we need to remember. So the final NEETPG pattern insight you need to have. Initial test, ceruloplasmin. Definitive test, liver copper. So that's what we have to basically remember. So in this context, because Wilson is asked, a storage disease is asked, examiner's question bank is full of storage disorders. You need to be 100% sure on this table, doctor. Run, run, run. Remember, baito dos ke saath ratta marna. Gotches, beta glucose ribrosidase. And there is a crinkled tissue paper appearance of macrophages. Niemann-Pick sphingomyelinase, and there is a cherry red spot and hepatosplenomegaly. Tay-Sachs is hexosaminidase A. It is the GM2 ganglioside accumulating cherry red spot, but no hepatosplenomegaly, unlike Niemann-Pick. Fabry, alpha galactosidase A. Ceramide trihexoside is the one which is deposited. Angiokeratomas, neuropathy is Fabry. Galactocerebrosidase is Crabby. Globoid cells is Crabby. Metachromatic leukodystrophy, aryl sulfatase, and it leads to demyelination. Forms is acid maltase, glycogen storage, cardiomegaly plus hypotonia. Hurler is alpha L-hydrogenase, dermaton sulfate, and you have a coarse phases with developmental delay. Hunter is hydrogenate sulfatase, dermaton sulfate, no corneal clouding. Hunter has no corneal clouding. If it is there, how can he hunter? So easy way to remember. So once more, all the glycogen storage disorders, what are the enzymes, what is the organ involved, what is the clue? Favorite question. One guy, type 1 glucose 6 phosphatase, liver is involved. Severe hypoglycemia. Type 2, acid maltase, heart, cardiomegaly. Cori, type 3, debranching enzyme, liver is involved, mild hypoglycemia. You need to master this table, doctor. Aapke mutti mein rehna, ratta marna, and be ready for the tomorrow's exam. So if you look at Tay-Sachs, Niemann-Pick, you should know how to differentiate in exam hall. Cherry red spot, present in both. Hepatosplenomegaly, only in the Niemann-Pick, not in Tay-Sachs. Right? Only in Niemann-Pick, not in Tay-Sachs. And hexosaminidase A is Tay-Sachs. Niemann-Pick is sphingomyelinase. Lot of times they will be going round and round and round of this fact. Be very sure of the examiner's pattern, doctor. Now, in Tay-Sachs, there is no hepatosplenomegaly. Niemann-Pick, there is hepatosplenomegaly. And the central retinal artery occlusion also can lead to cherry red spot, but that leads to sudden vision loss is what you need to remember. Then mucopolysaccharidosis and the inheritance. If it is Hurler, autosomal recessive, Hunter, X-linked. Favorite question of the examiner. Corneal clouding in Hurler. Severity, Hurler is more severe. So that's what you need to remember. Gotcha, crumpled paper macrophages. Go to the Google and check the image, crumpled paper. Every time INICET, every time NEETPG, without a question on one of the storage disorders, there is no paper. Tay-Sachs, cherry red, no HSN. Niemann-Pick, cherry red with HSN. Fabry, angiokeratoma, it is X-linked. F is female, X-linked. So X-linked is more common in the males. Pomp, cardiomegaly. McArdle, they have a muscle glycogen phosphorylase is the enzyme which is affected. They have an exercise intolerance is what you need to remember. So, doctor, 5,000 NEETPG patterns. We will discuss in about 200 hours, and all this video is made available in the video library, and you will get all this PDF mailed to you for you to do the quick revision of all the tables, right? But what I want to tell you is keep practicing these tables, these questions. After all, 5,000 patterns. And it's so easy if you have the determination to do the revision, and automatically questions come from this. All 200 out of 200 in the NEETPG come from this. A patient has xanthomas on the Achilles tendon. What is the likely diagnosis, doctor? Familial hypercholesterolemia, 2024 NEETPG question paper. So, hyperlipoproteinemias. What type of lipid increased? What is the xanthoma type? What are the clinical clues? Favorite question of the examiner. So, tendon xanthoma, eruptive xanthoma, tuberous xanthoma, plain xanthoma, and xanthelasma on the eye. You need to know all the 5 types. Tendon xanthoma is found on Achilles tendon, extensor tendons, typically in familial hypercholesterolemia, which is type 2A. Eruptive xanthomas is on the buttocks. It is type 1. Type 5, there are increased triglycerides is buttock. Tuberous xanthomas are there on the elbows and knees in type 3. Plain xanthoma is palmar, once more type 3. Xanthelasma is on the eyelids. That can be found on any hyperlipidemia. So, there is a Fredrickson's classification which you have to be sure, doctor. Type 1, typically, chylomicrons are increased. Chylomicrons contain the exogenous triglyceride. Triglyceride is increased. Lipoprotein lipase deficiency, it can lead to pancreatitis. Type 2A is LDL. Cholesterol increase, familial hypercholesterolemia, you find tendon xanthomas. Type 2B, both LDL, VLDL, cholesterol plus triglyceride, because VLDL is there. It's called mixed or combined. Type 3, IDL, where cholesterol plus triglyceride, disc beta lipoproteinemia, where you find palmar xanthomas. Type 4 is VLDL, triglyceride is increased, hypertriglyceridemia, alcohol. Type 5, chylomicrons, VLDL is increased. Both of them are carriers. One is exogenous, other is endogenous triglycerides. So triglycerides is increased and it is severe. So whenever Achilles tendon xanthoma is there, think of familial hypercholesterolemia. Palmar crease xanthoma is there, think of type 3. Recurrent pancreatitis with triglyceridemia, type 1 and 5. Orange colored tonsils. So many times image-based MCQs came. Remember Tangier's disease. Now coming to Tangier. What is the defect in Tangier? ABCA1 transporter defect. HDL is decreased. Tonsils are orange colored. And there are xanthomas, not tendon. That's the important thing about Tangier. So xanthoma, type 2A, it is on tendon. Type 3, it is palmar. Lipid, type 2A is LDL increased, but IDL increased in type 3. And the risk of type 2A is atherosclerosis, is what you need to remember. So any Achilles tendon, type 2A, familial hypercholesterolemia, you need to be 100% sure about. So hyperlipidemias, hypolipidemic drugs, lipid metabolism in biochemistry, every NEETPG paper out of 201 guaranteed. So, if you look the various drugs, LDL increase is most common feature. Normally, it should be less than 100 without risk factors. With risk factors like diabetes, less than 70. So, increased LDL. You have to give statins like atorvastatin. Increased triglycerides, we give fibrates, fenofibrate. You get Stanlip 145 milligram, 160 milligram, 2 compositions, triglyceride decrease. Both LDL and triglyceride increase, then you need to give statin plus fibrate combo. Increased VLDL, we give fibrate once more because Fibrates carry, VLDL carry triglycerides. Then HDL, if it is decreased, the only drug that can help is niacin nicotinic acid, very dirty drug that increases HDL. And in familial hypercholesterolemia, just not statin is enough. We have to combine ezetimibe, which blocks the absorption of the cholesterol from the gut. So you should remember, statins, HMG-CoA reductase inhibition, which is the rate limiting step. Fibrates, lipoprotein lipase increased triglyceride breakdown. Niacin decreased VLDL synthesis and increased the HDL. Ezetimibe decreased the cholesterol absorption from the intestine. And PCSK9 inhibitors, they increase the LDL receptors and powerfully decrease the LDL is what you have to remember. Now, the side effects pattern, you have to be 100% sure, doctor. So, every time when you are going for the NEETPG, unless you have made a darshan to these hyperlipidemias, hypolipidemic drugs, lipoprotein metabolism, you are not going to the exam at all. Fibrates, gallstones, statins, myopathy, plus increased LFT. Niacin lead to flushing because of release of prostaglandins. Niacin can lead to hyperglycemia, diabetes risk. Bile acids resins lead to constipation. Ezetimibe is safe and very minimal side effects. PCSK9 inhibitors, injection site reaction is what you have to remember. When you combine statin plus fibrate, myopathy risk is very high. Niacin plus statin increases niacin toxicity. Right? Bile resin with any other drugs will decrease even the drug absorption. So they're all the important combinations you need to remember. So when familial hypercholesterolemia, statins, hypertriglyceridemia, fibrates, low HDL, niacin, statin intolerance, you need to give ezetimibe is what you need to remember. So look at the key word examiner is proposing. LDL increase, statin. Triglyceride increase, fibrate. Flushing, niacin. Myopathy, statin. Gallstones, fibrate. Buzzword you need to catch in the tomorrow's NEETPG exam, doctor. So this is the approach you need to have when you go to the NEETPG exam, doctor. Take 2000 MCQs of the past, 2400 of past 12 years. Then we take 4000 PYQs of INI-CET. Every question, we try to identify what are the tables we need to create. And remember, know what is the exam pattern of the examiner and do the revision. So in totally 200 hours, I'm going to make you the champion and a winner in the NEETPG exam. 2 hours every day we will try from tomorrow, right? And this PDF which you are seeing here, please do WhatsApp 9000868 I am typing the number. You can also see in the title and below this video. WhatsApp and join for this 100 days, 2 hours daily boot camp to build 5,000 NEETPG patterns from which 200 MCQs in the tomorrow's NEETPG are going to come. Good luck, and we'll meet every day and we'll study every day and become confident. We'll cut all the noise. We will cut all what is not required. We will go very focused, ready to attack the reverse engineered examiner's question bank with 100% guarantee of what examiner asks. We should be prepared and go to the exam. Thank you.